Hi, this is Dr. Neurosurgery Greenberg, and today we are going to be discussing the surgical treatment and the pre-op endocrinologic evaluation of craniopharyngiomas. Because the area is the same, that is to say, the sella, we have to do the same pituitary tumor-like endocrine evaluation. And if there is any hypoadrenalism, you have to correct it first, and because of the risk of Addisonian crisis. But if there is hypothyroidism, you have to treat it after treating the hypoadrenalism, and hypothyroidism takes a lot longer. And then there are approaches. So you cannot approach a craniopharyngioma through the transsphenoidal route. You have to go transcranially, and you can make a frontotemporal flap, and you have to go as low as possible along the base of the frontal fossa, and you can even drill out the greater wing of the sphenoid, and you can approach the tumor extraaxially. And all tumors should first be aspirated, and after that you can take it out microscopically. So there are many approaches. One of them is subchiasmatic, which is the space between the optic nerves and the chiasm. So you go between the nerves, and if you go between the nerves, there are certain things that you need to know. That is, the chiasm may be prefixed or postfixed. Usually the chiasm sits right on top of the sella, but sometimes it can be prefixed when the chiasm is in front of the sella. And in that case, it is thought that the optic nerves will be small. And sometimes the chiasm is behind the sella. In that case, you might think that, okay, the optic nerves are longer. So it was thought that when the chiasm is prefixed, then there is not a lot of space to work on the tumor. But now it is said that actually in craniopharyngioma patients, the tumor has made the nerves come closer to the chiasm. So it's okay to use this approach as well. But sometimes you have to approach it from the side. The tumor can be approached from the side by the opticocarotid route, and that is between the optic nerve and the ipsilateral internal carotid artery. So usually we go through the right because left is the dominant side, so we use the right side. And then there is a lamina terminalis approach, and you can also go for a transfrontal transsphenoidal approach as well. And yes, transsphenoidally, if you can, what you can do is you can go up to the tumor and you can aspirate some fluid and then leave a stent in there, so that there is continuous drainage of the cholesterol crystals. There is no meningitis, and also the tumor gets decompressed. Then there is a transcallosal that will be only for tumors that are strictly purely ventricular. And after that, there is a combined subfrontal terional approach and extended approaches. So you can use any of these, but you have to make sure not to harm the small arterial feeders on the undersurface of the chiasm. And if while taking the tumor off, you have to make sure that the hypothalamus is not injured. Then post-op, you can give steroids to the patient because they are all going to be hypoadrenal, and you have to give hydrocortisone. And then diabetes insipidus, you have to make sure that you replace it with fluid replacement. And if it is not getting out of hand, you can use a vasopressin, which is going to prevent the renal shutdown. So that is it. And then radiation. Actually, you can't give much radiation in this area because of optic apparatus. Then there is dementia and endocrine dysfunction as well. So you can't give much radiation. And there is a little bit of 5 to 10% of mortality, mostly because of hypothalamic injury. And if there is a bilateral hypothalamic injury, it will produce hyperthermia and somnolence. And damage to the anterior osmoreceptors will lead to a loss of thirst sensation. And sometimes they can become recurrent as well. And if you do a reoperation, then the mortality is very high. So that is all about the craniopharyngioma management. Now coming to tumors of the neurohypophysis and the infundibulum. So this is a group of low-grade tumors that are going to arise from the pituicytes of neurohypophysis, which is posterior pituitary and the infundibulum. And there are pituicytomas, granular cell tumors, spindle cell oncocytomas, and they all show expression of thyroid transcription factor 1. And they are not actually pituitary adenomas because they are not coming from the anterior pituitary, but they are almost never considered as a part of our differential, and they are that rare. So the presentation is just like any other pituitary adenoma: visual field deficits, um, classically bitemporal hemianopia, hypopituitarism, headache, diabetes insipidus, pre-op diabetes insipidus, right? And hypercortisolism and acromegaly can also happen in these patients. Now, the imaging, they are actually identical to adenomas, and they are isodense on CT, isointense on T1, and they have dense homogeneous enhancement on CT and MRI. And you have to do a gross total resection, but the spindle cell oncocytomas have a higher recurrence rate. And if you already know that this is something different, then you should go transcranially, because these are very, very vascular, and because of their vascularity, transsphenoidal resection is not possible. And if you have done a subtotal resection, then you can go for radiotherapy. Coming to pituicytoma, which is WHO grade 1, it is circumscribed and it has bipolar spindle cells arranged in a fascicular or storiform cat-wheel pattern. Very little mitotic activity. Very little mitotic activity, and they are only found in adults. And the location of the tumor should be cellar or supracellar, and there are bipolar spindle cells, and there is nuclear TTF1, which is thyroid transcription factor 1 expression, and that is the diagnostic criteria for it. Then coming to the granular cell tumor of the cellar region. It is also a circumscribed tumor, and it has nests of large cells having granular or eosinophilic cytoplasm because of cytoplasmic lysosomes. Mitotic activity is very rare. And if you are thinking about any neurohypophysis or infundibular tumor, then this is the tumor which is the most common one. And it likes to exist in the stalk. It likes to grow in the stalk, and so it has a supracellular extension. And the germ cell tumors are also present in other parts of the body, like the GI tract or the orbit, or even the spinal meninges. And it's more common in females, and they have a benign tumor behavior, right? And for them, again, there will be TTF1 expression. The tumor will be in the cellar or in the supracellular location, and there will be no pituitary hormone and no pituitary transcription factor expression. Okay, that's how we differentiate it from pituitary adenomas. Then coming to the spindle cell oncocytoma, it is not just supracellular but intracellular as well. Sometimes there is invasion of the cavernous sinus and even the floor of the cella, and they are highly vascular, so they can undergo spontaneous hemorrhage, and there is also significant blood loss during surgery. So you have to be careful while operating them, and again, transcranial will be the route to go. And there will be TTF1 expression, the location will be cellar or supracellular, and there will be no pituitary hormone transcription factor expression. So that is all about pituicytomas. I will see you in the next video, and thank you so much, and God bless.